Chapter 33, Assessment of the Hematologic System. We begin with subjective data and getting that past health history. And a health history for hematopoietic system consists of demographic data, current health, their past health history, past and current use of medications, surgical history, herbal preparations, and nutritional supplements. That CAM therapy is especially necessary to assess. And this will go along with a thorough family health history, a review of symptoms, and their functional health patterns. We're also going to assess a previous hematologic problems such as anemia, bleeding disorders, or blood diseases, disorders or injuries or transplants involving the liver, kidney, or spleen, alcohol or IV drug use, a history of recent or recurrent infections, or problems with blood clotting. This would go along with other diseases such as leukemia, hepatitis, or cirrhosis, just to name a few. A complete medication history should also include the use of prescriptions, over-the-counter drugs, vitamins, herbal products, and dietary supplements, as many have the potential to interfere with normal hematologic function. Remember that when many patients may not consider pills obtained without a prescription as drugs, they definitely are. Herbs can interfere with blood clotting. Anti-neoplasmic or malignant disorders, along with antiretroviral agents such as with HIV, may cause bone marrow suppression. And previous chemotherapy, particular alkylating agents, put patients at a higher risk for developing secondary malignancies, such as leukemia or lymphoma. Also, the long-term use of anticoagulant therapy can increase the risk of bleeding problems. Also, ask the patient about specific past surgical procedures because of their significance. The duodenum is where the iron absorption occurs. Partial or total gastrectomy involves the removal of parietal cells, thus reducing intrinsic factor needed for the absorption of cobalamin and vitamin B12. Gastric bypass means the duodenum may be bypassed and the parietal cell surface again decreased. And then ileal resection because it's where cobalamin absorption takes place. Assess how wound healing progressed post-operatively, and ask when any bleeding problems occurred in relation to the surgery. Also include information such as past injuries, including minor traumas and dental extractions. Finally, determine the number of previous blood transfusions and their possible complications during administration, because this could increase the risk of transfusion reactions and iron overload, which further increases the number of blood transfusions. Gather complete demographic data, including age, gender, race, and ethnic background. The family history of hematologic problems helps identify genetically linked disorders, specifically jaundice, anemia, malignancies, sickle cell disease, or other red blood cell disorders. And also, you want to carefully assess for bleeding disorders such as hemophilia and other clotting disorders. Assess for risk factors such as alcohol, illicit drugs, and cigarette use. Alcohol is caustic to the GI mucosa and can cause GI bleeding, esophageal varices, and decreased absorption of cobalamin and other nutrients, resulting in vitamin deficiencies. Chronic alcoholism can also damage platelet function of the liver, affecting the production of clotting factors and leading to bleeding problems. Also, many illicit drugs can affect hematopoiesis. Cigarette smoking increases low-density lipoprotein, or LDL cholesterol, and the levels of carbon dioxide, leading to hypoxia and altering the anticoagulant properties of the endothelium. Furthermore, smoking increases platelet reactivity, plasma fibrinogen, hematocrit, and blood viscosity. Hematologic problems with a strong genetic link include sickle cell anemia, hemophilia, thalassemia, and hemochromatosis. They also predispose a person to the development of the same issues. Other hematologic problems could include leukemia, pernicious anemia, and clotting disorders that also may have a genetic predisposition. Obtaining the patient's weight and determine if the patient has experienced anorexia, nausea, vomiting, or oral discomfort. A dietary history may provide clues about the cause of anemia. Iron, cobalamin, and folic acid are necessary for the development of red blood cells. And iron and folic acid deficiencies are often associated with inadequate intake of foods such as liver, meat, eggs, whole grain, and enriched breads and cereals, potatoes, leafy green vegetables, dried fruits, legumes, and citrus fruits. Hematemesis, or bright red, brown, or black vomitus, is a manifestation of an underlying problem and should always be investigated. Peptic ulcer disease is a common cause. Explore any changes in the skin's texture, including color or temperature, as well as asking about any bleeding from anywhere on the body. Also, asking about any lumps or swelling within the neck, armpits, or groin. Asking what they feel like and if they are mobile or fixed, and if they are tender. Primary lymph tumors are usually not painful. Lymph nodes that are enlarged and tender are usually associated with an acute infection. Determine if the patient currently has a fever, recurring fevers, chills, or night sweats. Cardiovascular disorders such as valvular disease or hypertension may also predispose patients to hemolysis. Many of the medications used to treat cardiovascular disease can also cause abnormalities within the hematopoietic cell production or anticoagulation. Pulmonary disorders that lead to hypoxemia may cause chronic stimulation of erythropoietin and result in polycythemia, excess red blood cells. Assess the patient's elimination, including urinary output, diarrhea, blood in the urine or stool, and a history of black tarry stools, recently tested for occult blood or colonoscopy. Assess for symptoms of tiredness, weakness, and complaints of heavy extremities, as well as apathy, malaise, dyspnea, or palpitations. Note any change in the patient's ability to perform regular exercise or the normal activities of daily living, especially as they relate to patient safety and a possible history of falling. Determine the patient's feelings of being rested after a night's sleep, as fatigue secondary to a hematologic problem will often not be resolved following sleep. Arthralgia, or joint pain, may indicate an autoimmune disorder such as rheumatoid arthritis, or it may be caused by gout secondary to increased uric acid production as a result of hematologic malignancy or hemolytic anemia. Aching bones may also result from pressure of expanding bone marrow with diseases such as leukemia. On the other side, hemarthrosis, blood in the joint, occurs in the patient with bleeding disorders and can be painful. Hemarthrosis. Determine the effect of the health problem on the patient's perception of self and their personal abilities. Also assess the effect of certain problems such as bruising, petechiae, and lymph node swelling on the patient's personal appearance. Question the patient about any past or present occupational or household exposures to chemicals or radiation, and if such exposure has occurred, determine the type, amount, and duration of the exposure. A person who has been exposed to radiation as a treatment modality or by accident has a higher incidence of certain hematologic problems. The same is true of a person who has been exposed to chemicals such as benzene, lead, naphthalene, or phenylbutazone. They're commonly used by potters, dry cleaners, and individuals involved with occupations that use adhesives. Ask the patient about a history in the military as well. Many Vietnam veterans were exposed to dioxin-containing defoliant, which has been linked with leukemia and lymphoma. I can tell you in Iraq they were exposed to a lot of chemicals as well. I mean, our cop in Diyala province, Iraq, had a big burn pit right in the middle of it. Obtain a careful menstrual history from women, including the age at which menarche and menopause began, the duration and amount of bleeding, the incidence of clotting and cramping, and any associated problems. Ask men if they have any problems related to impotence, because this is not uncommon in men with hematologic problems. Also, question the patient about their sexual behavior, because HIV infection is potentially a concern, particularly among high-risk groups. Ask the patient if adequate support is available to meet their ADLs. Furthermore, determine their usual methods of handling stress and their day-to-day routines. In the patient with platelet disorders or hemophilia, the potential for hemorrhage may be so frightening that usual life patterns may be drastically curtailed, affecting their quality of life. If blood transfusions or bone marrow transplant treatments cause any conflicts with the patient's cultural or religious beliefs, and notify the healthcare provider if conflicts are identified. Some hematologic problems are treated with blood transfusion or a bone marrow transplant. Determine if these types of treatments conflict with the patient's value belief system, including the patient's cultural and religious beliefs related to blood and transfusions. A complete physical examination is necessary to accurately examine all systems that affect or are affected by the hematologic system, depending on the nature of the patient's problem, including an assessment of lymph nodes, liver, spleen, and skin. Disorders of the hematologic system can manifest in various ways. Thus, a patient's presenting symptoms may not immediately point to a hematologic problem. Here we have a diagram showing the distribution of lymph nodes throughout the body. Superficial lymph nodes can be evaluated by light palpation, while deep lymph nodes cannot be palpated and are best evaluated by radiologic examination. The lymph nodes should be assessed symmetrically in regard to location, size, the degree of fixation, tenderness, and texture. To assess superficial lymph nodes, lightly palpate the nodes using the pads of the fingers, and then gently roll the skin over the area and concentrate on feeling for a possible lymph node enlargement. Ordinarily, lymph nodes are not palpable in adults. If a node is palpable, it should be small, mobile, firm, and non-tender to be considered a normal finding. A node that is tender, hard, fixed, or enlarged is an abnormal finding, and it warrants further investigation. Both the liver and spleen are normally not detectable by palpating the abdomen. The spleen may be more difficult to detect because of its deep location in the left abdomen. An enlarged liver is noted by measuring the number of finger breadths it extends below the ribcage border. The spleen is usually quite difficult to palpate. The skin should be examined over the entire body in a systematic manner. In patients with red blood cell disorders, the skin may be pale or have pasty skin tones, or even a cyanotic tinge in severe anemia. Erythrocytosis often produces small vessel occlusions, causing a purple, mottled appearance of the face, nose, fingers, or toes. Clubbing of the fingers can be seen with chronic anemia, such as in patients with sickle cell disease. And leukocyte disorders may cause infectious skin lesions, or malignant nodular lesions. These may occur anywhere and have a variable distribution pattern. Look carefully for petechiae or ecchymoses, which is bruising, because these findings can indicate bleeding disorders. The most direct means of evaluating the hematologic system is through laboratory analysis and other diagnostic studies. The complete blood cell count involves several laboratory tests, each of which serve to assess the three major blood cells formed in the bone marrow. A peripheral smear is used to look at the morphology, shape, and appearance of the blood cells. Although the status of each cell is important, the entire system may be disrupted by diseases as well as the treatment of the disease. When the entire CBC is suppressed, a condition termed pancytopenia, or marked decrease in the number of red blood cells, white blood cells, and platelets exists. Normal values of some red blood cell tests are based on body mass, thus they are different for men and women. Anemia, hemorrhage, and states of hemodilution, such as those that occur when the fluid volume is excess and can cause reduced red blood cell results. Increases in red blood cell tests are found in polycythemia, or in states of hemoconcentration, which can develop from volume depletion, dehydration. Hematocrit helps determine the percentage of red blood cells compared to the total blood volume, and the hematocrit value generally is 3 times the hemoglobin value. Red blood cell indices are special indicators that reflect red blood cell volume, color, and hemoglobin saturation, and can provide insight into the cause of anemia. Erythrocyte sedimentation rates, or ESRs, or even a SED rate, measures the sedimentation or settling of red blood cells, and is used as a nonspecific measure of many diseases, especially inflammatory conditions. White blood cell elevation does not necessarily predict the severity of illness, but can provide clues to the etiology of health problems, such as infection, inflammation, tissue injury, or malignancies like leukemia and lymphoma. Certain types of leukemias are more likely to produce extremely high white blood cell counts. The differential white count identifies the percentage of different types of white cells within the circulating blood. The white blood cell differential is of considerable significance because it is possible for the total white blood cell count to remain essentially normal despite a marked change in one type of leukocyte. A normal platelet count is anywhere between 150,000 to 400,000. Counts below 100,000 signify thrombocytopenia, a condition in which bleeding may occur. Spontaneous hemorrhage is possible once platelet counts fall below 10,000. Thrombocytosis is defined as excessive platelets, which is a disorder that occurs with inflammation and some malignant disorders. The most likely complication related to thrombocytosis is excessive clotting. The Rh system is based on a third antigen, D, which is also the red blood cell membrane. Rh-positive people have the D antigen, whereas Rh-negative people do not. A Coombs test is used to evaluate the person's Rh status. As a result of transfusion therapy or during childbirth, an Rh person may be exposed to Rh-positive blood. After exposure during childbirth, the mother forms an antibody, anti-D, which acts against the Rh antigens. In subsequent pregnancies, the mother's anti-D antibodies can cross the placenta and attack the red blood cells of a fetus who is Rh positive, thus causing hemolysis of the red blood cells. A pregnant Rh-negative woman should receive RhoGAM injections to prevent the anti-negative D antibodies from forming. A major factor in healthy functioning blood is iron. Iron is obtained from food and dietary supplements. Approximately 1 milligram of every 10 to 20 milligrams of iron ingested is absorbed in the duodenum and upper jejunum. Most is bound to the heme in blood as hemoglobin and in the muscle as myoglobin. The other one-third is stored as ferritin and hemosiderin. in the blood, bone marrow, spleen, liver, and macrophages. When the stored iron is replaced, hemoglobin production is reduced. Transferrin, which is synthesized in the liver, serves as a carrier plasma protein for iron. The degree to which transferrin is saturated with iron is a reliable indicator of the iron supply for developing red blood cells. There is normally very little iron loss except from blood loss because iron is recycled after macrophages in the liver, spleen, phagocytose old and damaged red blood cells, and only about 3% is lost daily in urine, sweat, bile, and epithelial cells in the GI tract. The laboratory tests used in evaluating iron metabolism and differentiating anemias between measuring serum levels of iron, total iron binding capacity, and serum ferritin and transferrin saturation. Serum iron is a measurement of the amount of protein-bound iron circulating within the serum. These provide a measurement of all proteins that act to bind or transport the iron between the tissues and bone marrow. Although this indirect measurement is a general reflection of the amount of transferrin present in the circulation, it overestimates transferrin levels by 16 to 20% because it also measures other proteins that can bind iron. These alternative proteins only bind iron when transferrin is more than half saturated. Also, these tests can vary inversely with the tissue iron stores. It's higher when iron stores are low and lower when iron stores are high. A transferrin saturation is a better indicator of the availability of iron for erythropoiesis than serum iron because, unlike serum iron, the iron bound to transferrin is readily available for the body to use. Under normal conditions, the serum ferritin concentration correlates closely with body iron stores. In a normal patient, 1 nanogram per milliliter of ferritin corresponds to roughly 8 to 10 milligrams of stored iron. Radiologic studies for the hematologic system involve primarily the use of CT or MRI for evaluating the spleen, liver, and lymph nodes. Biopsy procedures specific to the hematologic system are bone marrow examination and lymph node biopsy. In general, these procedures are done because a peripheral blood smear is nonspecific, and usually a diagnosis cannot be established from a peripheral blood smear. A biopsy also provides additional information about hematologic problem that's needed for diagnostic purposes, as well as planning treatment options. Bone marrow examination is important in the evaluation of many hematologic disorders. The examination of the marrow may involve aspiration only or aspiration with biopsy. The benefits gained from bone marrow examination are a full evaluation of hematopoiesis and the ability to obtain specimens for cytopathology and chromosomal abnormalities. The preferred site for both aspiration and biopsy of bone marrow is the posterior iliac crest. After a bone marrow aspiration and biopsy, the site must be assessed frequently on the day of the procedure and for several days thereafter. Patients can experience some discomfort or pain and can require a mild analgesic. And finally, a lymph node biopsy involves obtaining lymph tissue for histologic examination to determine the diagnosis and to help for a planning therapy. These can be accomplished by either an open biopsy or a closed needle biopsy. Only a positive result is adequate for confirming a diagnosis. A negative result may be a reflection of the sample and not necessarily a diagnostic indicator. Testing for specific genetic or chromosomal variations in the hematologic conditions is often helpful in assisting in diagnosing in stages. These results will also help to determine the treatment options and prognosis. Testing is usually done on samples from bone marrow, lymph node biopsies, and sometimes cerebrospinal fluid. For example, fluorescent in situ hybridization may be used to illuminate an abnormal extra chromosome that is common in certain leukemias by targeting a specific region of DNA. But anyway, that's all we've got for this chapter. I'll see you in the next slide where we'll get much deeper into our specific hematologic problems.